Maturity onset diabetes of the young. Maturity onset diabetes of the young MODY refers to any of several hereditary forms of diabetes mellitus caused by mutations in an autosomal dominant gene disrupting insulin production. MODY is often referred to as monogenic diabetes to distinguish it from the more common types of diabetes, especially type 1 and type 2, which involve more complex combinations of causes involving multiple genes and environmental factors. MODY 2 and MODY 3 are the most common forms. Robert Tattersall and Stefan Fajans initially identified the phenomenon known as maturity onset diabetes of the young in a classic study published in the journal Diabetes in 1975. Signs and symptoms. MODY is the final diagnosis in 1%–2% of people initially diagnosed with diabetes. The prevalence is 7,110 per million people. 50% of first-degree relatives will inherit the same mutation, giving them a greater than 95% lifetime risk of developing MODY themselves. For this reason, correct diagnosis of this condition is important. Typically, patients present with a strong family history of diabetes any type and the onset of symptoms is in the 2nd to 5th decade. There are two general types of clinical presentation. Some forms of MODY produce significant hyperglycemia, the typical signs and symptoms of diabetes, increased thirst and urination, polydipsia, and polyuria. In contrast, many people with MODY have no signs or symptoms and are diagnosed either by accident, when a high glucose is discovered during testing for other reasons, or screening of relatives of a person discovered to have diabetes. Discovery of mild hyperglycemia during a routine glucose tolerance test for pregnancy is particularly characteristic. MODY cases may make up as many as 5% of presumed type 1 and type 2 diabetes cases in a large clinic population. While the goals of diabetes management are the same no matter what type, there are two primary advantages of confirming a diagnosis of MODY. Insulin may not be necessary, and it may be possible to switch a person from insulin injections to oral agents without loss of glycemic control. It may prompt screening of relatives and so help identify other cases in family members. As it occurs infrequently, many cases of MODY are initially assumed to be more common forms of diabetes, type 1 if the patient is young and not overweight, type 2 if the patient is overweight, or gestational diabetes if the patient is pregnant. Standard diabetes treatments, insulin for type 1 and gestational diabetes, and oral hypoglycemic agents for type 2 are often initiated before the doctor suspects a more unusual form of diabetes. Genetics. Some sources make a distinction between two forms of monogenic diabetes, MODY, and neonatal diabetes. However, they have much in common and are often studied together. Heterozygous. MODY is inherited in an autosomal dominant fashion, and most patients therefore have other members of the family with diabetes. Penetrance differs between the types from 40% to 90%. Homozygous. By definition, the forms of MODY are autosomal dominant, requiring only one abnormal gene to produce the disease. The severity of the disease is moderated by the presence of a second. However, conditions involving people carrying two abnormal alleles have been identified. Unsurprisingly, combined homozygous defects of these genes are much rarer and much more severe in their effects. MODY, homozygous glucokinase deficiency causes severe congenital insulin deficiency resulting in persistent neonatal diabetes mellitus. About 6 cases have been reported worldwide. All have required insulin treatment from shortly after birth. The condition does not seem to improve with age. A MODY-IFR homozygous IP phone results in failure of the pancreas to form. Congenital absence of the pancreas, termed pancreatic agenesis, involves deficiency of both endocrine and exocrine functions of the pancreas. Homozygous mutations in the other forms have not yet been described. Those mutations for which a homozygous form has not been described may be extremely rare, may result in clinical problems not yet recognized as connected to the monogenic disorder, or may be lethal for a fetus and not result in a viable child. Pathophysiology. The recognized forms of MODY are all due to ineffective insulin production or release by pancreatic beta cells. Several of the defects are mutations of transcription factor genes. One form is due to mutations of the glucokinase gene. For each form of MODY, multiple specific mutations involving different amino acid substitutions have been discovered. In some cases, there are significant differences in the activity of the mutant gene product that contribute to variations in the clinical features of the diabetes, such as degree of insulin deficiency or age of onset. Diagnosis. The following characteristics suggest the possibility of a diagnosis of MODY in hyperglycemic and diabetic patients. Mild to moderate hyperglycemia, typically 130–250 mg/dl or 714 mmol/L, discovered before 30 years of age. However, anyone under 50 can develop MODY, a first-degree relative with a similar degree of diabetes. Absence of positive antibodies or other autoimmunity, e.g., thyroiditis, in patient and family. However, Urbanova et al. Found that about 1/4 of Central European MODY patients are positive for islet cell autoantibodies GABA and IATWO-A. Their expression is transient but highly prevalent. The autoantibodies were found in patients with delayed diabetes onset and in times of insufficient diabetes control. The islet cell autoantibodies are absent in MODY in at least some populations, Japanese, Britons. Persistence of a low insulin requirement, e.g. less than 0.5 U/kg/day, past the usual honeymoon period. Absence of obesity, although overweight or obese people can get MODY or other problems associated with type 2 diabetes or metabolic syndrome, e.g. hypertension, hyperlipidemia, polycystic ovary syndrome. Insulin resistance very rarely happens. Cystic kidney disease in patient or close relatives. Non-transient neonatal diabetes or apparent type 1 diabetes with onset before 6 months of age. Liver adenoma or hepatocellular carcinoma. Renal cysts, rudimentary or bicornuate uterus, vaginal aplasia. Absence of the vas deferens. Epididymal cysts in MODY type 5. The diagnosis of MODY is confirmed by specific gene testing available through commercial laboratories. Classification. Common or well-established forms of MODY: 1% of MODY or greater HN-phone and MODY 3, HN-F4 modion and GCK moditwo, HN-phone B modifiv, ABC sate MODY 12 KCN 11 MODY 13, INS moditin. Rare forms of MODY: few families, described but reasonable generic evidence for causing MODY: neurodun MODY OSIX, IP-phone/PD zone MODY IFR, cell MOD8, WS phone and RFX66. Genes reported as causal for MODY but evidence not compelling: BLK MODY 11, PAX4 MODY A9 and KL11 MODY A7, APP lone MODY I13 in KX6-1. Treatment. Epidemiology. According to data from Saxony, Germany, MODY was responsible for 2.4% of diabetes incidence in children younger than 15 years. History. The term MODY dates back to 1964, when diabetes mellitus was considered to have two main forms, juvenile onset and maturity onset, which roughly corresponded. MODY was originally applied to any child or young adult who had persistent, asymptomatic hyperglycemia without progression to diabetic ketosis or ketoacidosis. In retrospect, we can now recognize that this category covered a heterogeneous collection of disorders which included cases of dominantly inherited diabetes, the topic of this article, still called MODY today, as well as cases of what we would now call type 2 diabetes occurring in childhood or adolescence, and a few even rarer types of hyperglycemia. Many of these patients were treated with sulfonylureas with varying degrees of success. The current usage of the term MODY dates from a case report published in 1974. Since the 1990s, as the understanding of the pathophysiology of diabetes has improved, the concept and usage of MODY have become refined and narrower. It is now used as a synonym for dominantly inherited, monogenic defects of insulin secretion occurring at any age, and no longer includes any forms of type 2 diabetes. Miscellaneous. MODY should not be confused with latent autoimmune diabetes of adults LADA, a form of type 1 DM, with slower progression to insulin dependence than child-onset type 1 DM, and which occurs later in life.